Welcome back to the deep dive. Today we're getting into a really important topic, especially if you're in medicine or maybe prepping for exams like the MSRA, perhaps.
Yeah, absolutely vital.
We're doing a deep dive into hyperkalemia.
That's right. And the sources we're looking at today, they're basically a set of focused revision notes, a medical overview, really designed to get straight to the point on hyperkalemia.
Exactly. So our aim here is to, break this down, pull out those really crucial bits of information, the high yield stuff, and help make it stick for you.
Yeah, consider it your kind of focused guide. We're unpacking these notes, highlighting what you really need to know for practice or revision, and hopefully explaining the why behind it too.
Okay, let's jump right in then. The absolute basics first. What is hyperkalemia?
Well, simply put, it's just having an elevated level of potassium in your blood serum. But that simple definition carries some serious weight.
And these notes give a specific number for that, right? A threshold.
They do. It's defined as a serum potassium level greater than 5.5 millimoles per liter. So 5.5 millimole.
Okay, 5.5, that's the number to lock in. And why is it so potentially serious? You mentioned it carries weight.
Because high potassium, especially if it's untreated, can really mess with the heart's electrical signals. The notes stress it can lead to life-threatening cardiac arrhythmias. It's often a medical emergency.
Wow, okay, so straight away it's potentially critical.
Definitely. And the source material highlights right at the start. Alongside knowing the level, you got to think about what's causing it, like an acute kidney injury, maybe, and also stop any drugs that might be making it worse. Things like ACE inhibitors are a classic example.
Right, address the cause, stop aggravating factors.
Right.
Makes sense. Now, you mentioned 5.5 as the starting point. Do the notes break down different levels of severity?
Yes, they provide a pretty clear classification. Mild hyperkalemia is 5.5 up to 5.9 millimole.
Okay.
Moderate is 6.0 to 6.4 millimole.
Right.
And severe is anything 6.5 millimole or higher. Knowing these levels helps you gauge, the urgency needed.
So 6.5 or more, or even slightly lower with symptoms, perhaps, you're thinking severe and act fast.
Precisely. That's the trigger point for immediate action in most guidelines.
Okay, let's unpack the why then. Why does potassium go up? What are the main sort of buckets of causes the notes talk about?
The notes group them quite logically. The biggest category is often renal causes, basically problems with the kidneys because they're so crucial for getting rid of potassium.
Makes sense.
So things like acute kidney injury, AKI, or chronic kidney disease, CKD, are major players here. The kidneys just aren't filtering properly. Also, lots of common drugs can interfere with kidney function or the whole renin-angiotensin system that controls electrolytes.
Okay, so poor kidney function means poor potassium excretion. Got it. What else?
Another big area is increased circulation of potassium. This would be from outside sources, like someone taking way too many potassium supplements, which is less common perhaps, but possible.
Right.
Or, more often maybe, it's potassium leaking out from inside the body's cells. This happens with significant cell damage. The notes mention things like tumor lysis syndrome, where cancer cells break down really fast. Or rhabdomyolysis, that's severe muscle breakdown, or even major trauma. Lots of cell damage releases intracellular potassium.
So either too much potassium coming in from outside or it's pouring out from damaged cells inside.
Exactly. And the third main category is a shift from intracellular to extracellular space. See, most of the body's potassium is actually inside the cells.
Right.
If something causes it to shift out into the bloodstream, your serum level spikes, even if the total amount in your body hasn't changed much. The classic cause the notes mention here is acidosis.
Oh, yeah, like in DKA, diabetic ketoacidosis.
Exactly. That's a prime example. The body tries to buffer the acid by moving hydrogen ions into cells, and potassium ions move out to maintain electrical balance.
Clever, but problematic.
Very. Certain medications can also cause this shift. Digoxin toxicity is one. Succinylmethonium used in anesthetics, even some beta blockers. And there's a rare genetic thing called hyperkalemic periodic paralysis, too.
Okay, so renal, increased load or a shift out of cells. And wasn't there one more sort of odd one out?
Ah, yes. Pseudohyperkalemia. This isn't real hyperkalemia in the patient's body. It's a lab artifact.
A fake result. How does that happen?
Yeah, basically. The notes list common reasons like maybe the blood draw was difficult, causing red blood cells to burst in the tube. It's hemolysis.
Right, releasing their potassium.
Exactly. Or if the sample gets shaken too much or sits around for too long before being analyzed, even contamination from IV fluids containing potassium. It's really important to think about this, especially if the high number doesn't fit the clinical picture.
That's a really key practical point, isn't it? Always question a surprising K+ result. Could it be the sample?
Definitely worth considering.
The notes also flag up some special considerations or risk factors. Who should we be particularly mindful of?
They definitely highlight key groups. Advanced age is a risk factor, probably due to, gradual decline in kidney function and often taking more medications.
Makes sense.
Chronic kidney disease and diabetes mellitus are big ones, explicitly mentioned. They often go together too, compounding the risk. And, like we touched on, certain medications are major risks. The notes specifically call out ACE inhibitors and potassium-sparing diuretics again.
So that classic patient profile, older, maybe diabetic with some CKD on an ACE inhibitor. Hyperkalemia risk is definitely elevated there.
Hugely. You need high vigilance in those patients. The notes also add interesting points like dehydration can worsen the risk, and even strenuous exertion, particularly in dehydrated people. They even mention sickle cell trait as a specific scenario where this might happen.
Strenuous exertion, that's surprising.
It is, isn't it? It shows how potassium balance can be quite sensitive in certain situations.
Okay, so we know what it is, why it happens, who's at risk. But let's get down to the mechanism. How does high potassium actually cause problems? What's the pathophysiology?
Right, this is key to understanding the symptoms. The notes remind us potassium is absolutely vital for normal cell function, especially nerve and muscle cells. Think about the heart. It relies on precise electrical signals.
Yeah, the whole action potential thing.
Exactly. Potassium levels inside and outside the cell create an electrical gradient, the membrane potential, which allows cells to fire, to conduct impulses. High potassium outside the cell messes up this gradient.
It dampens down the cell's excitability.
Essentially, yes. It makes the resting membrane potential less negative, closer to the threshold for firing. This sounds like it would make cells more excitable, but it actually impairs their ability to repolarize properly, making it harder to generate and conduct subsequent impulses correctly. This electrical disruption is what leads to the muscle weakness and, crucially, the cardiac problems.
Got it. That link between the ion level and the electrical function is critical. So connecting that to the patient, what signs and symptoms might you actually see? What clinical features do the notes list?
Well, the notes emphasize variability. Symptoms might be vague or even absent, especially if the potassium rises slowly. But when they do occur, the common ones are muscle weakness, which can sometimes progress all the way to paralysis.
Serious weakness.
Yeah. Then cardiac arrhythmias. The patient might feel palpitations, or you might detect a slow heart rate, bradycardia, or signs of heart block on examination or ECG. General feelings of nausea and fatigue are also common.
Okay, muscles, heart, feeling generally unwell.
Sometimes tachypnea, rapid breathing, can happen if the respiratory muscles are weak. And the notes also mention occasional features like actual paralysis, shortness of breath, possibly chest pain. On exam, reflexes might be depressed or absent.
It sounds like it can affect multiple systems then.
It definitely can. But the notes also stress, again, that the severity of symptoms doesn't always correlate perfectly with the potassium number. A rapid rise might cause more dramatic effects than a slow, chronic elevation to the same level.
Important point. And what about physical exam findings? Anything specific usually?
Often, the physical exam can be surprisingly normal, according to the source. The big exceptions would be finding, say, severe bradycardia, or if the cause is rhabdomyolysis, you might find tender or obviously weak muscles.
So you can't rely on the exam alone to rule it out?
Absolutely not. A normal exam doesn't mean the potassium isn't dangerously high.
Okay, so suspicion is high, maybe based on risk factors or vague symptoms, or just a routine blood test comes back high. How do we investigate properly?
First step is obviously confirming the serum potassium level. And remembering our earlier point, always consider if it could be pseudo-hyperkalemia. Maybe repeat the sample carefully if it seems odd.
Right. Check the number. Check if the number is real. What else?
Essential blood tests listed include urea, electrolytes, and creatinine, U&E. This is absolutely crucial to check kidney function given it's such a common cause.
Standard stuff.
Yeah. Checking glucose levels is important. Are they sky high, suggesting DKA? A full blood count, FBC, might give clues in specific situations like tumor lysis. If the patient takes digoxin, definitely check a digoxin level. And an arterial blood gas, ABG, is really useful. It confirms acidosis, which can cause a potassium shift, and it gives you another potassium reading to compare with a venous sample.
So a good set of bloods to get the context. But the ECG, the notes really seem to emphasize the ECG changes.
They do, because the ECG shows the effect of the high potassium on the heart muscle, which is where the immediate danger lies. It's critical.
So what are the classic changes we should be looking for?
The notes list a typical progression, although it's not always perfect or stepwise in every patient. The earliest, most classic sign is peak T-waves. Think tall, narrow, tented T-waves.
Dented T-waves, got that visual. What comes next?
As potassium climbs higher, you might see the PR interval prolong, get longer. Then the P wave starts to flatten out and can eventually disappear altogether.
P wave disappearing.
Okay. Then the QRS complex begins to widen. This is a really ominous sign, meaning the electrical signal is traveling much more slowly through the ventricles.
Wider QRS, definitely bad news.
Yeah. This can progress further to things like AV dissociation, where the atria and ventricles are beating independently. And then the really scary one is the sine wave pattern, where the widened QRS merges with the T wave, looking like a sine wave on the trace. That's basically pre-arrest.
Wow, that progression is terrifying. From peak T's to a sine wave.
And the final stage listed is asystole, flat line.
Grim. But there was a really important caveat the notes mentioned about the ECG.
Yes, absolutely crucial, especially for exams in real life. The ECG can be normal despite severe life-threatening hyperkalemia. This is a massive point.
So you absolutely cannot be falsely reassured by a normal ECG if the potassium level is, say, 7.0.
Exactly. Especially if that rise was rapid or the patient seems unwell.
Yeah.
You treat the number and the patient, not just the ECG tracing. You can't rule out danger based on a normal ECG alone.
That's such a vital take-home message. Okay, we found it. We've investigated. Let's talk management. How do we fix this? What are the goals?
The goals outlined are twofold. First, stabilize the cardiac membrane, protect the heart from the potassium's effects. Second, lower the serum potassium level. And the urgency is dictated by that number. Is it 6.5 or by any ECG changes? If either of those is present, it's an emergency.
Right. So immediate actions for those severe ECG change cases. What's the first thing you do?
The absolute first, most critical step for cardiac protection is intravenous calcium. The notes specify calcium gluconate, usually 30 milliliters of 10%, or calcium chloride, 10 milliliters of 10%. This acts fast to stabilize the heart muscle cell membranes.
Okay, calcium first to protect the heart. Does it lower the potassium level itself?
No, and this is a really key point to remember. Calcium does not lower serum potassium. It just buys you time by making the heart less sensitive to the high potassium.
Essential distinction. Calcium protects, doesn't remove. So how do we actually lower the potassium?
The notes describe two main strategies here: shifting potassium into cells temporarily and actually removing it from the body. For the short-term shift, the go-to treatment is a combined insulin and dextrose infusion.
The old insulin-dextrose combo.
Yep, usually 10 units of rapid-acting insulin, like Actrapid, mixed in 50 milliliters of 50% glucose. The insulin drives potassium into the cells, and the glucose stops the patient becoming hypoglycemic.
Makes sense. Anything else for shifting?
Nebulized salbutamol, like Ventolin, is also listed. High doses can also push potassium into cells, although maybe less reliably or effectively than insulin dextrose. It's often used as an adjunct.
Okay, so calcium for the heart, then insulin glucose, and maybe salbutamol to shift K plus inwards temporarily. What about getting rid of it permanently?
That's the removal strategy. The notes mention calcium resonium, or similar potassium-binding resins. You can give it orally or as an enema. It binds potassium in the gut, preventing absorption and promoting excretion in feces.
Okay, resonium binds it in the gut.
Loop diuretics, like furosemide, can also help if the patient has some remaining kidney function. They increase potassium excretion through urine.
Makes sense. Force it out via the kidneys.
And then, the most definitive removal method, especially if the kidneys aren't working well, like in AKI, or the hyperkalemia is severe and refractory, is dialysis. Hemodialysis is very effective at pulling potassium out of the blood.
Right, that artificial kidney. So the notes have that practical approach for severe cases.
Yes, for severe 6.5 or ECG changes. Start with 5-E calcium gluconate, stabilize, then give the insulin dextrose infusion, shift. Consider nebulized salbutamol, additional shift.
And then longer term, or once the immediate crisis is managed.
Then it's about stopping any offending drugs, definitely treating the underlying cause, manage the kidney injury, sort out the DKA, whatever it is, and use those removal methods, resonium, diuretics if appropriate, or arranging dialysis to bring the total body of potassium down.
What about cases that are difficult to manage, resistant hyperkalemia?
Yeah, the notes touch on this. You might need repeat doses of insulin glucose or calcium. 4V diuretics like furosemide might be considered, especially if there's fluid overload alongside. Crucially, they advise discussing with renal specialists if the potassium stays stubbornly high.
Get the experts involved.
Definitely. They also mentioned sodium bicarbonate might be useful if there's significant metabolic acidosis. But again, the recommendation is to use this after discussion with renal specialists. And in really extreme cases, like refractory cardiac arrest due to hyperkalemia, hemodialysis might be needed urgently.
Okay, so a clear, stepwise approach. Stabilize, shift, remove. Calcium, insulin glucose salbutamol, then resonium diuretics dialysis, while treating the cause and stopping bad meds.
That's a pretty solid framework based on these notes, yeah.
So finally, what's the general outlook? The prognosis. And what are the absolute worst things that can happen in the complications?
Prognosis really hinges on the underlying cause, how severe the hyperkalemia got, and crucially, how quickly it was recognized and treated. The notes say that with prompt, appropriate management, the outlook is generally good.
That's reassuring.
It is. But severe, untreated hyperkalemia is dangerous precisely because of the potential complications.
Which are mostly heart-related, I assume.
Predominantly, yes. The big ones listed are severe cardiac arrhythmias, things like ventricular fibrillation or asystole, which are obviously catastrophic.
Cardiac arrest territory.
Exactly. It can also cause that profound muscle weakness we mentioned, potentially leading to paralysis, including respiratory paralysis in severe cases. So yeah, the ultimate complication is cardiac arrest and death. But the notes really stress these are often preventable with timely action.
Right. So if you connect this to the bigger picture, getting good at spotting and managing hyperkalemia quickly isn't just academic, it's literally about preventing patients from dying from sudden cardiac events.
Couldn't have put it better myself. It's a fundamental skill.
Well, that feels like a really comprehensive run-through of hyperkalemia, pulling out all the key bits from these revision notes. We've covered the definition, the causes, the risks, the pathophysiology, how it looks clinically, those vital ECG changes, and the management framework stabilize, shift, remove.
Yeah, hopefully breaking it down step by step like that helps cement the key concepts for anyone listening, especially if you're revising.
Definitely. And maybe one final thought to leave you with, based on what we discussed. We highlighted that critical point of how severe hyperkalemia can sometimes show no ECG changes at all. How does knowing that challenge your approach? When you see that high potassium number pop up on the blood results, what's the very first thing you must consider, even if the ECG looks perfectly fine?
It just hammers home that you have to assess the whole picture, the patient in front of you, the number itself, and the ECG. But you can't let a normal ECG lull you into a false sense of security if that potassium level is significantly high. Clinical assessment and the actual K+ value are paramount.
Absolutely. Now, if you want to really consolidate this, working through some practice questions is often the best way.
Agreed. And for that, the notes specifically recommend checking out two websites if you're prepping for exams like the MSRA or just want to test yourself. They are passthemsra.com and freemsra.com.
Passthemsra.com and freemsra.com.
Yeah, both have resources, question banks that cover topics just like this one, helping you apply the knowledge in exam-style scenarios. Really useful stuff.
Great recommendations. Well, thank you so much for joining us for this deep dive into hyperkalemia. We really hope distilling these notes has been useful for your learning and revision.
Definitely. Go back over the key points. Think about those ECG changes, the management steps. You'll get it.
And we'll catch you on the next deep dive.